Good morning. I'm Vignesh from Medicine 2. So I'll be speaking on the topic pneumonia for the next 45 minutes or so. The topic being a bit broad, it's not possible to cover the whole topic of pneumonia in 45 minutes, but I'll try to give some overview and then finally we can have some discussions. And in between, I have also inserted some Slido questions so as to just extend my presentation to 1 hour, but I can also ask for an excuse saying that it's to keep you all awake. So, we'll, so the outline of my presentation will be starting with definition, some classification, microbiology, pathogenesis, clinical features, investigations, treatment, prevention, and most of it will be covering community acquired pneumonia, but we'll end up with a very few a brief overview on how ventilator associated pneumonia and healthcare associated pneumonia differs from community acquired pneumonia, and then we'll open the session for some discussion. So pneumonia is an infection of the pulmonary parenchyma. That is the definition. And there are various terminologies such as community acquired, nosocomial pneumonias, hospital acquired pneumonias, ventilator acquired, and healthcare associated pneumonias. So to call it as a community acquired pneumonia, it has to be acquired out of hospital, or it should have been acquired within 48 hours of hospital admission. Whereas in nosocomial pneumonia should have been acquired while in hospital, and there should have been a minimum duration of stay of 48 hours in hospital. And the nosocomial pneumonia is further divided into hospital acquired and ventilator acquired pneumonia, depending on whether the patient has been intubated and put on ventilator. So if it has been 48 hours on intubation and ventilation, it is called ventilator acquired pneumonia. But if it has occurred in the setting of a non-intubated, non-ventilated patient, it is called hospital acquired. And there is a terminology called healthcare associated pneumonia, which is no longer in use. It, it was used in the setting where someone has been recently in a hospital setting, or someone is in a residential care facility or a nursing home, which is supposed to be one of the discharge destinations for older gentlemen, predominantly in the West, in order to identify susceptibility to resistant pathogens. But the drawback of this was that there was overuse of antibiotics, so which has led when it has not been warranted, so it has led to the phasing out of this terminology called healthcare associated pneumonia. So currently what we have is broadly classified as community acquired and nosocomial is subdivided into hospital acquired and ventilator acquired pneumonia. That is the existing terminology. So looking at the problem burden, this is from the US. Pneumonia due to an infectious cause accounts to about 1.2% of ED visits among all the diagnoses. So 1.2% is pretty big number. And regarding mortality, this is from vital statistics of the US for 2021. And it says that there have been 41,000 odd deaths, and it has been 12.4 deaths per 100,000 population. Microbiology. So we start off with a Slido question. With the current available diagnostics, what is the most common isolate identified during evaluation of community acquired pneumonia? %. Good. How many of you have seen a streptococcal pneumonia in the last 1 month? Okay. And there is one in medicine too now. There is one, but it's a meningitis. Yes, I agree. 50% influenza, pneumonia. Okay, some change in trends. Okay, sure. Yeah, so correct. Majority of you are right, because most often, even where we have the most of the molecular methods available, around 60 to 65% of the times, community acquired pneumonia, we do not have an organism which could be isolated for community acquired pneumonia. So it's only the remaining 35 whom we can rank, and among those, we can say which one is the most common and not. So that is where we are at. So microbiologically, the etiological agents are classified as typical bacterial infection and atypical bacterial infection and viral causes. So the reason why they are called typical, any reasons why they are called typical? Okay. Yeah, so one thought process is that typical pneumonia, when we say, it presents with typical features of pneumonia: cough, fever, expectoration, maybe chest pain, and they have characteristic features of consolidation in the form of bronchial breath sounds, bronchophony, egophony, all those things. So as you said, the presence of consolidation, which is lobar pneumonia, presents with typical features, and these bacteria are associated with typical features. The other reason is that typical bacteria are usually susceptible to the usual beta-lactam antibiotics. That's one other reason why they are called typical bacteria. So strep pneumonia is the most common one, with Haemophilus influenzae, Moraxella, Staph aureus, Rupius strep, and some aerobic gram-negative bacteria and microaerophilic bacteria and anaerobes, which are associated with aspiration. And in contrast, atypical infection may not present with those typical symptoms, but may present with some malaise, fatigue, tiredness, body aches and pains. And in addition, they will present with some respiratory signs and symptoms. And these are intrinsically not responsive to the usual conventional beta-lactam antibiotics. So that is the reason why they are called atypical bacteria. And the examples being Legionella, Mycoplasma, Chlamydia, Coxiella, which are the atypical ones. And viruses, influenza and SARS-CoV-2 are the ones which we usually commonly see here. But in addition, there are also other viruses like rhino parainfluenza, adeno, RSV, metapneumoviruses, which can also be identified if we send a multiplex PCR. We'll come to whether you need to use all these diagnostics or not in routine practice in a little while. Okay, coming on to risk factors. So the common risk factors for acquiring pneumonia is age. So age more than 65 supposed to be one of the most important risk factors for acquiring pneumonia. And chronic comorbidities would be the second one. And among the comorbidities, this is a graph taken from up to date. So it shows that most often it is secondary to COPD and and also due to congestive heart failure, stroke, diabetes, smoking, and obesity are supposed to be the most common comorbid conditions which are associated with pneumonias. And third are viral respiratory tract infections such as influenza or any of the other respiratory viruses that we discussed now, which can predispose to a secondary bacterial infection as well subsequently. It is mainly because of the impaired airway defense mechanisms that predisposes to a secondary bacterial infection. So impaired airway protection in the form of underlying lung diseases such as COPD, bronchiectasis, which can predispose to pneumonia. Smoking, alcohol use, and recreational drug use alcohol use, especially more than 80 grams per day, and is associated with pneumonia again. And certain other lifestyle factors such as occupational exposures, occupational lung diseases also predisposes. And in pathogenesis, there's something new about pathogenesis. So the new terms that are usually used while describing the pathogenesis of pneumonia are lung microbiota and dysbiosis. Just similar to normal flora which are present in the gut, genitourinary tract, there are supposed to be some normal commensals which are present in the airways as well. So it is thought that there is an imbalance between the pathogenic organisms and the commensals, which predisposes to pneumonia. So this is taken from one of the Nature Review journals, which is the official publication of the Association of Microbiologists of India. And it gives a list of all the organisms which are present in the upper airways and up to the lungs, and also in the oropharyngeal region. So to concentrate specifically on the lungs, the most common commensals are Prevotella, Streptococci, and Veillonella. And it's usually the lung clearance mechanisms which are responsible to maintain the commensals and prevent any of the pathogenic bacteria to affect this balance. And whenever there is an impaired clearance mechanism, it predisposes to pneumonia. And the source from which we get pathogenic organisms are various, from the gingiva, periodontal region, from the esophagus, nasal cavity, oropharynx, and stomach, secondary to aspirations of gastric contents and aspiration of any of the infected oral and oropharyngeal contents. So this is what usually happens in eubiosis, which is the normal homeostasis, where there is a basal immune tone which is being maintained, and there is some residual microbial DNA, and there are the defense cells, macrophages and neutrophils sitting there. And when there is an aspiration event happening, wherein oral commensals enter the lungs, there is an activation of macrophages and neutrophils, and which subsequently results in bacterial elimination. So what happens when there is a recurrent microaspiration? That is when there is early dysbiosis and immune imbalance. So when this episode happens in a recurrent fashion, there is a release of multiple interleukins, there is increased antibody response, and there is an immune imbalance of the Th1, the helper 1 and 2 cells. And this results in persistent dysbiosis, and it results in a biofilm formation, wherein there is a mixture of pathogenic bacteria as well as the commensals. And just to give you an example, that's the reason why we have a few of the bronchiectatic patients being Pseudomonas colonizers without being actually infected as such. So it becomes a colonizer, and it remains, and it affects the microbiome of the lungs, and thereby it predisposes to the development of recurrent infections as well. So coming on to clinical features, not just going, I mean, this you should, it should all be aware. So there's no need for me to repeat what are the clinical features of pneumonias. So what I'll be running through is to look at some of the interesting features of clinical features of pneumonias. So this is a snapshot from CMDT 2023, which says that the essentials of diagnosis for a community-acquired pneumonia being fever or hypothermia, with some tachypnea, cough, expectoration, dyspnea, chest discomfort, sweats or rigors or both. On examination, presence of bronchial breath sounds, sometimes bronchial on auscultation, and chest X-ray showing a parenchymal opacity, but it's not usually, it's sometimes not evident on presentation, especially early in the course of pneumonia. The consolidation may not be well visible in a chest X-ray. and it should have occurred outside the hospital or within 48 hours of hospital admission, as I mentioned earlier. So given that it is pretty straightforward, how straightforward it is. So the next few slides are from JAMA's Users Guide to Rational Clinical Examination. So this is the result of a study, Spiteri et al., wherein they asked 9 physicians to counter check each other's findings for a patient who has got respiratory signs and symptoms. Interesting to note that there has not been a great deal of agreement between either two physicians when they tried to examine these findings. So the best agreement seems to be for increased tactile fremitus, and say wheeze and crackles have got something less than 80, and even tachypnea there has been an agreement of only 63. So there has, I mean, if we look at the kappa statistics, which is called the agreement statistics, it has been usually between 0.3 to 0.5 or something like that, which amounts to fair to good agreement between observers. So it says that there is inter-observer variability for reproducing or identifying the presence or absence of respiratory symptoms. And then looking on the likelihood ratios for various symptoms of respiratory illnesses. So I mean, this is a busy slide with a lot of numbers, but grossly, just to give a rough idea, a positive likelihood ratio or a likelihood ratio of a positive test is greatest if it is, say, around 10 or something like that. And similarly, a likelihood ratio of a negative test is greatest if it is somewhere around 0.1 or something or lesser. But if we look at the numbers, they are all just scattered between 1, 2, that seems to be the maximum. And similarly for the negative likelihood ratio, it's around 0.78 or sometimes even more than 1. That has been the trend. So what it says is that a single symptom is not a very good predictor of identifying pneumonia. So we can't make a diagnosis of pneumonia just because someone is coughing or someone is producing sputum or someone has got fever or sore throat or something. But what's interesting here is that a medical history of asthma, according to this particular one study, negatively is associated with presence of pneumonias. Possibly that most of the asthmatics, if there is a past medical history of asthma and if they develop any of these symptoms, it's most likely an exacerbation of asthma rather than a pneumonia. That's probably the explanation why it has got a significant negative association with pneumonia. So we have looked at the historical findings. Next, going on to the examination findings. So examination findings wise, the same trend happens. So most of the likelihood ratios appear to be in the 3s and 4s. Egophony is the one which has got 8.6. And similarly for the negative ones, there are no numbers which are in a good range to effectively rule out the presence of pneumonia. So the summary of it is that neither of one of the historical findings or examination findings is sufficient enough or good enough to make a diagnosis of pneumonia. So what is the way to go about is some of them have tried to devise some predictive scoring systems by using a combination of history features and examination features. But even when they have tried various permutation combination of various, depending on the likelihood ratio, say whatever has got the best positive likelihood ratios, they just take them, and similarly from history, whatever has got the best positive values, they take them and see which one best predicts, which model predicts best. And depending on which, there have been quite a few scoring systems which have been devised. But even if we use the combined likelihood ratio of those various algorithms, when we assume that the prevalence is say around 5%, the post-test probability has not crossed over 40 to 50%. So that's once again an indication that even if you're going to combine 4 or 5 features, it's not going to be a great predictor of community acquired pneumonia. So what is the essence finally after looking at all these tables? It's just to emphasize that history and clinical examination is very important, that we have to identify as many findings as possible so as to make a diagnosis of community acquired pneumonia. It's not sufficient that we take 1 or 2 and do it. So it's also important to make sure that we do a meticulous examination, including all the vital signs, your percussion, auscultation, and auscultate, especially for the presence of bronchophony, egophony, pectoraloquy. So when we arrive at a combination of findings, that is when the diagnosis of community acquired pneumonia is likely to be closer to 100%, and which we can confirm with a chest X-ray and other corroborating blood investigations. So coming on to investigations. So investigations, once again, I'm not going to go through the common investigations in detail. So the basic investigations including blood counts, renal functions, whether to go ahead with inflammatory markers, I'll come to it in a short while. And chest X-ray. So just I want you to look at these chest X-rays carefully, and I'll be putting a Slido question subsequently. Yeah. Which among the above is an abnormal X-ray? Is it only A? A will be 1 to your left. B, are both of them abnormal or neither of them abnormal? Okay. At mixed views. Yeah, just by grossly looking at it, both of them appear to be more or less similar. And yeah, just on a first look, maybe justified if you are going to say both of them are normal or both of them are abnormal. Okay, a tough competition. If I show this one, the lateral view of the first X-ray. Here we are not used to so much of lateral X-rays, so sometimes it might be a bit hard to identify abnormalities in a lateral X-ray. So just show a comparison of a normal lateral X-ray and the current lateral X-ray. So this is a normal lateral X-ray, where you see that the retrocardiac shadows are pretty much clear and the vertebral vertebral bodies are reasonably clearly visible. Whereas in compared to here, the cardiac shadow is here, and whereas the retrocardiac A region has got quite a few opacities that you are not able to make out the vertebral bodies very clearly. So in essence, that there is a possibility that we can miss a left lower lobe pneumonia or left lower zone pneumonia when we are doing a chest X-ray AP or a PA view alone. So that's the importance of doing a lateral view as well. But is there any way that we could have identified some abnormality in the PA view at all? Going back, so what is difference between these two is that here we are able to see the diaphragm pretty clearly visible, the diaphragmatic margin, whereas in this first X-ray, the diaphragm is silhouetted by the opacity. So we are not able to trace the diaphragm only up to the lateral border of the heart, but we are not able to trace it any further. So that will be one of the clues where we can suspect the presence of a retrocardiac shadow, which could be confirmed subsequently by doing a lateral view chest X-ray. Sure. So what about the role of sputum culture and a blood culture? So there has been some change in the guidelines have been pretty much okay, pretty much the same. So they, in essence, if it is a mild pneumonia, we don't go ahead doing a sputum culture, or it's not recommended to do a routine sputum culture or a blood culture, but we do it in patients with severe pneumonia or in pneumonias whom we are empirically treating with anti-pseudomonal cover or an anti-MRSA cover. Because if we are going to cover that, we need some guide whether those antibiotics need to be continued or whether they can be de-escalated. So for that purpose, we definitely need a culture. So in those patients, definitely it is recommended. But whereas in milder pneumonias whom we are planning to treat as an outpatient, we are just treating with oral antibiotics, which are not going to be active against Pseudomonas or MRSAs, then we do not need to routinely do a sputum culture or blood culture as per the 2019 American Thoracic Society IDSA guideline. Okay, so as I was saying, we have got some molecular methods available. We have got all the PCRs, legionella antigens, all those which are available to us right now. So should we be sending all those for all patients? So this is a European guideline which has been published for only severe community acquired pneumonias, and it has been published in 2023, now recently, in the last 1 or 2 months or so. So it says that it's a very low quality evidence, as it says here, and this indicator is supposed to be a conditional recommendation. So it's not routinely recommended, but can be done if the technology is available to send some lower respiratory tract samples, either from sputum or ET aspirate, for multiplex PCR testing, either for virus or bacterial detection, whenever non-standard antibiotics are prescribed or considered, which is pretty much in line with the previous one. So whenever we are going to cover with an anti-pseudomonal antibiotic or an anti-MRSA antibiotic, it's essential that we need to have some microbiology. So it's suggested that we do any of the molecular methods. But whether will this be cost effective if we are going to do it for all patients? It's a question mark, because I think our multiplex PCR costs about 6,000, 7,000. And the only one which we are going to probably treat is influenza. And even if we give oseltamivir for 5 days, it's not going to cost 7,000. So we might as well just give 5 days of oseltamivir rather than treat it from a patient perspective, especially a financial perspective, because the patient pays for all the tests here. And even if it is from a healthcare perspective, whether it would be reasonable for the government to give multiplex PCR free of cost, or whether they can give oseltamivir free of cost. which will be beneficial for the exchequer. It's once again might be in favor of giving just oseltamivir because it's obviously cheaper. But one way that we can justify is some of the not easily identifiable outcomes. Say if we identify influenza, then we advise them to isolate, then we decrease the disease burden, so minimize the spread. So in that case, on a long term, maybe minimize the use of oseltamivir, in which case it may probably become cost effective. But we need to have some good data, good studies, and good health economic studies to arrive at these conclusions. So it's not a ready answer, but we can do it from for an epidemiological perspective, or we can derive some personal satisfaction that we have found out an organism and we can report it. So for that purpose, it will help. But from a management perspective, from a patient perspective, it may not have great implications. So that's why it is still a conditional recommendation, and we still have very low quality evidence at present. So next is prediction of severity of pneumonias. You have heard of various scoring systems. So maybe I'll let you type in some scoring systems that you know of. Okay. I think most of you have given most of the scores. I'm going to put up in the subsequent slide. So which of these scores are better? So we don't have too much data to compare the various scores, but this is one study which was done in Australia to compare various scores, and it was used to predict a 30-day mortality or ICU admission. And if we look at it, I'm just looking at the sensitivity and specificity. And yeah, before that, there are a few other scores as well, curb 65 PSI, which we commonly use, and CORB corp score, and some Kirk score, IDSA score, and a smart score. So these are various scores. Looking at it as to which has got the best numbers, it appears that curb 65 and corp score have got the best specificity to for predicting 30-day mortality or ICU admission. So what does it literally mean? If the curb score is 3 to 5 or the corp score is 2 to 4%, 93 or 94% of the times they will either require an ICU admission or they will have mortality before 30 days. But there is a possibility that 6% of the times it may not happen. 6 to 7% of the times. And this is not a fixed number. There is a confidence interval for that as well. So when we say 94%, it can be as bad as 92 to as good as 96. Similarly, corp can be as bad as 90 and as good as 95% for specificity. So next is smart corp score, which is has got 85% sensitivity, meaning if smart corp is less than 3, then 85% of the times the patient will not require ICU admission or will not have a 30-day mortality. But 15% of the times, even if the smart corp score is going to be less, they still could require ICU admission or they still may die at the end of 30 days. That's what it indicates. So given all these complex numbers, which is the best score? Maybe I could have put another Slido question after showing this slide, but unfortunately the free version apparently allows only a fixed number of questions, so I couldn't put any more questions. Curb 65. Smart cop. The answer is it depends. It depends on what you want. If you want to, if you are going to be in ED and if you want a score which will permit you to send off the patient safely, then you want a test which is going to be very sensitive so as to rule out the possibility of a 30-day mortality or an ICU admission. So this is in the setting of an ED if you're going to be sitting in ED. But if you are going to see a patient in the ward and you want to give a prognosis or some financial explanation to the patient, and if you want to accurately predict whether this patient will require an ICU admission or not, then you will need a probably highly specific score so that you can tell them that it looks like it is very likely that you might require an ICU admission. So be prepared for this, so much of finances, etc. So in that case, you will need a score which is going to be more specific. So it depends on the scenario, what you want from the score. So if you want something to rule out, then probably smart cop score seems to be the best among the lot. It's not the greatest, but seems to be the best among the lot. Also along with this Kirk score, which also has got somewhere in the 80s. And if we need a specific one, then curb 65 seems to be fulfilling the needs. But also we have to keep in mind that even though this seems to be the point estimate, the confidence interval can be as bad as 75 to 92%. So are you going to be happy with a 75% sensitivity? Meaning 25% of the times, if you're going to send away a patient from ED, there is a chance that he may come back requiring ICU. Is that a low enough number that you're going to be happy with? If yes, then probably you can use smart cop. If you are not going to be happy, then probably you're not going to use smart cop. So also there has been one study in which in Australia they have done to look at the predictive value or predictive performance of these scores in the native or the aboriginal population, in which these scores have not fared very well when compared to the standard results that have been published previously. So it appears that there could be some population differences as well, where how these scores perform. So it might be a good exercise to see which will perform best in our population and then choose which one is best for us and take it from there. Next, moving on to treatment. So this is from our HICC 2022, which says that there have been 9 meningeal isolates and 29 non-meningeal isolates in the previous year. And since our topic is pneumonia, we'll concentrate more on the non-meningeal isolates. So it says that almost 100% of it is penicillin and cephalosporin susceptible, and obviously vanc susceptible as well. So that's probably something good, that we can treat most of the pneumococcal pneumonias with just penicillins or even cephalosporins. So this is once again from HICC, where the treatment guidelines is based on the curb score. So whenever it is less than or equal to 1, the most common organisms that are considered are strep pneumonia, mycoplasma, chlamydia. And the recommended oral regimen is amoxicillin with azithromycin or doxycycline as well for atypical cover. And when it is curb 2, warrants IV antibiotics, preferably under admission. And so the organisms are pretty much similar, but here we choose either penicillin or ceftriaxone, which is justified given that almost every, in fact, every isolate has been penicillin and cephalosporin susceptible. So this might be a reasonable option, with azithromycin for atypical cover and oseltamivir if we are going to suspect influenza. And if at all there is a strong suspicion of there being a pseudomonal infection, especially whom they have had hospital exposures or have an underlying lung disease, then we may prefer covering them empirically with piperacillin, tazobactam, azithromycin, and oseltamivir. And when the curb score is more than or equal to 3, where we are going, where we expect something more such as a Klebsiella pneumonia, which can sometimes be ESBL as well, which may not respond to piperacillin and tazobactam, then we'll try to hit hard, start with a more broader spectrum cover with meropenem, with azithromycin for atypical cover, oseltamivir. And if at all MRSA is suspected, say if the patient has had previous MRSA or has been a colonizer with MRSA, then we can consider adding on vancomycin. So given that fluoroquinolones also have got pretty good effect, as we saw previously, that it has got good effect with the non-meningeal isolates of pneumococcus as well. And it also has got reasonably good effect against the atypical organisms. Which one can we use? Whether we can use a macrolide or whether we can use a fluoroquinolone. So here again, the evidence is not very great. So it's a very low quality evidence because there is only one randomized control trial which has compared erythromycin with ciprofloxacin some few decades ago, and all the subsequent data, most of which have only been observational studies. So based on the observational studies, even though it's not at the highest level of evidence as per the evidence-based pyramid, it appears that macrolides have got a decrease in mortality when compared to fluoroquinolones by around 5 to 7%. And that is the reason why it happens to be a conditional recommendation that macrolide be used in preference to a fluoroquinolone. I mean, we can also justify it that fluoroquinolones, we would probably want to reserve it as an obvious anti-pseudomonal antibiotic. Also, when we are going to use it as an ADT, we would probably want to preserve it better rather than use it for all community-acquired pneumonias. So in that way, we can also justify the use of macrolides in favor of fluoroquinolones. And obviously, it's a conditional recommendation, and I think we also have we have enough reasons to follow this as well. And is there any recommendation on the ventilator strategy? So in hypoxic patients with severe community-acquired pneumonia, either whether we can use NIV or high flow. Once again, the quality of evidence is not very great, and it only happens to be a conditional recommendation again. So in someone who has got an acute hypoxic respiratory failure, not requiring immediate intubation, we can use high flow oxygen instead of standard oxygen. And similarly, NIV can be an option with someone who has got persistent hypoxemic failure, not needing immediate intubation, irrespective of whether they have been on high flow or on standard oxygen. So not very useful, but it says that we can probably consider if the patient is it may decrease the need for intubation in future if we are going to use high flow or if we are going to use NIV. And next, coming on to duration of antibiotic. So how long can we consider giving antibiotics for community acquired pneumonias? 5, 7, 10, 14. For some reasons, all of us like these numbers. None of us give 9 days of antibiotics or 11 days of antibiotics because they seem to be pretty odd numbers. So we are all like the end of something in multiples of 5 or multiples of 7 are the ones that we like. And many of the studies also do follow, use these durations. That's why we end up having these numbers. So once again, we don't have great evidence, but there is a meta-analysis which was published in 2019, which compared short duration antibiotic versus long duration, where they have defined short duration as less than or equal to 6 and long duration as more than or equal to 7. Don't know what that one day is going to change between short and long duration. But anyways, that found that less than equal to 6 seem to be pretty much similar in effect with the longer duration in terms of clinical cure. And in terms of mortality, in fact, lesser than or equal to 6 was found to be a little bit better when compared to long duration. But whereas for clinical cure, the confidence interval was crossing 1, so we can't make too much of an interpretation of that. So once again, the evidence is a little bit iffy, not very clear, but what we can say is that definitely they will need a minimum of 5 days of antibiotics. That will be recommended, but whether to give more or more than that, it depends on the severity of the pneumonia and the patient's response to antibiotics, depending on which we can decide on 1 week, or if the patient has got say severe community acquired pneumonia because of a resistant pathogen, we can consider extending it to 10 days, something like that. So once again, we don't have very high quality evidence to give you an answer as to this is the definitive duration of antibiotic. So the next is whether we can use procalcitonin to guide initiation or duration of antibiotics. One thing that we can be definitely clear is that procalcitonin is definitely not useful to decide on whether to start on an antibiotic or not. So if you suspect community acquired pneumonia, whatever be the irrespective of whether you want to do a procal or not, and even if you do procal, irrespective of what the answer is, start antibiotics. But where it can possibly be useful is that, say at the end of 48 hours, repeat a procalcitonin, and if the procalcitonin is, say, tenfold lesser, or if the value is less than 0.25, then and the patient is clinically better and clinically improved, then you can consider stopping the antibiotics. So it may be useful as a guide in addition to clinical features to stop antibiotics. So that is where procalcitonin is likely to be useful. So it is not a replacement of clinical judgment. It can probably add on to the clinical judgment to a certain extent. So that is the take home about procalcitonin. And other than that, as I want to insist again, it is not used as a guide to either initiate or not initiate antibiotics following a diagnosis of community acquired pneumonia. So next, steroids in community acquired pneumonia. So you think it will be useful? Not useful? Yeah, so this is one of the recent meta-analysis. In fact, I was supposed to have done this lecture a month ago. Thankfully, I was not ready then, that I have been able to include this in my presentation now because it has been published only after that. So I can use it as an excuse. So it has been a pretty good systematic review where they have searched most of the databases, including clinical trial registry, and they have not used language as a barrier. And it has been done by a group headed by a physician in McMaster University. So I've not gone into the details of all the methodology, but since it appeared to be of pretty good quality, I'm just going directly to the summary of findings table. So what is most important in this table is that in someone who has got more severe pneumonia, and when we take mortality as the outcome, there is a moderate quality evidence, and there appears to be a mortality benefit, meaning there is 56 fewer deaths, which can be either 22 fewer or 81 fewer deaths with corticosteroids. So there is a relative risk of 0.62. So, but in simple terms, the number of deaths appear to be lesser, and there seems to be reasonable certainty. And there is a moderate, it's a moderate quality evidence because there seem to be some discrepancy in the inclusion exclusion criteria of the various studies that have been used. So that is the reason why they have downgraded it by 1 and labeled it as a moderate quality evidence. Of course, for this, for a more severe disease, they have taken PSI of 4 and 5 to be severe, and when it comes to SMART COP, more than 5 to be severe, and curve of more than or equal to be 3 as severe. So whenever these are present, there is probably some role of steroids, especially in preventing mortality. And some other outcomes which also seems to have been a little bit beneficial is invasive mechanical ventilation and ICU admission. These also appear to be fewer and on one side of unity. So it's either 21 to 48 fewer per thousand requiring invasive mechanical ventilation and 2 to 29 fewer ICU admission. And steroids not being very expensive possibly can be considered if it is going to give all these benefits in terms of mortality, need for invasive ventilation and ICU admission. But most important to look at it is whether there are any adverse effects. So adverse effects, as expected, there is increase in hyperglycemia, which is either 35 to 87 more per thousand population. But secondary infections seem to be either 12 fewer or 32 more, which is on either side of 1. So maybe there may be more infections, there may be lesser infections, which we cannot definitely say. And similarly with GI bleed, there may be lesser GI bleed or there may be more GI bleed. So there is hyperglycemia, which is there. But if it is not going to result in mortality, then when compared to mortality, this appears to be a less significant adverse effect. So possibly we could consider giving steroids for patients with severe community acquired pneumonia. And one more thing is that this particular systematic review meta-analysis did not include any patients with viral pneumonias, COVID, or pneumocystis in pneumonias into this review. So it's all more for the community acquired pneumonias which do not have an organism or which have the typical and atypical organisms, which we had discussed earlier. So that is about the role of corticosteroids in this. And coming to this, they have also done some statistics to find out, because there has been different dosage of steroids that were used in different trials. What they have tried to do is calculate the equivalent of dexamethasone for 7 days, and they have tried to see which one of those has got the best risk reduction, which dose has given the best risk reduction. So looking at these numbers, it appears that the smallest number seems to be 0.45 for dexamethasone at a dose of 6 milligram per day for 7 days. Interestingly, is the dose that we use for COVID as well, moderate to severe COVID requiring oxygen as well. So this appears to be the dose which seems to be giving the best benefit, but it's not grossly different from 4 or 7 milligrams or even 8.5 or 3. It appears to be pretty much similar numbers. But what is here to see is that there does not seem to be any incremental benefit as we keep going up on the dose of steroids. Say, it's not that with increasing dose of steroids, the relative risk numbers are coming down further. So it is not a dose dependent response that we are getting for steroids, but it appears that the dose range somewhere between 3 to 8 to 10 milligrams of dexamethasone equivalent per day seems to be working to a reasonable extent. So 6 milligrams of dexamethasone per day would be equal to hydrocortisone of be equal to around 160 milligrams of hydrocortisone. So say if we give 50 TID to QID, that should probably be a reasonable dose if we are considering it for severe community acquired pneumonias. Okay, so now we have attempted treating pneumonias, and if there is no response or if symptoms continue to persist in spite of, say, 3-4 days of treatment, then what are the possibilities that we need to consider? That whether there is just a delayed response to the treatment, but more importantly, we should look for alternative sources, whether there is a loculated infection, say developing empyema or a lung abscess, or if there is an underlying bronchial obstruction secondary to a tumor, endobronchial tumor, which is preventing the clearance of the infection, or if there is an alternate organism, which is not the typical organism causing a community acquired pneumonia, such as nocardia, Mycobacterium tuberculosis, atypical, or Mycobacterium, or any of the fungal pneumonias, or if the diagnosis itself is wrong, whether we have missed some other inflammatory lung condition, say sarcoid or something like that, and we are treating it as a community acquired pneumonia. So these are the other differentials that we need to consider if someone is not responding to the appropriate duration of an appropriate antibiotic at an appropriate dose. So moving on to complications. So it can be secondary to progression of the infection in the form of empyema, lung abscess, bacteremia, or infective endocarditis, or it could be because of alternative hospital acquired infections secondary to hospital stay, say line related catheters, bed sores, or another hospital acquired pneumonia or ventilator acquired pneumonia. So those are other complications, infective complications that we expect. And there are also cardiovascular complications which have been documented secondary to pneumonias, especially secondary to streptococcal pneumonia and influenza. So it has been noted to cause myocardial infarctions, arrhythmias, heart failures, pulmonary embolism, and stroke. Can be just because of the disease process or an underlying heart disease which can predispose to it, but there also appears to be some hypothesis that it could directly cause myocardial toxicity or vessel wall injury in causing all these complications as well. So we do have one case series published, which was done as one of the conference presentations by one of our previous registrars. So heart failure among patients admitted with influenza in one particular unit. And in 5 years, there were about 93 patients who were admitted with influenza. And among those 14 patients, so 15% of patients who got admitted with influenza had heart failure. And among which it's notable that it was of a new onset in 10 patients. So 10 out of the 14 who developed heart failure in influenza happened to have a new onset heart failure with no prior heart disease existing. So we do have such data in support of the hypothesis that it can possibly directly cause some toxicity, causing cardiovascular morbidity. So prognosis, of course, we all know it has got short-term burden, which we have already looked at, but there appears to be long-term respiratory and cardiovascular sequelae as well, secondary to community-acquired pneumonias. This is once again US data, which has shown that at hospitalization, the mortality appears to be 6.5%, but it continues to rise over the next 1 year to 13, 23, and 31 till the end of 1 year after hospitalization, meaning that there appears to be some form of a long-term respiratory and cardiovascular sequelae as well, causing mortality. So the risk does not end once the pneumonia is treated, but continues to persist as well. But this requires some further studies in multiple other areas and good comparison before we can say that it is causative, or whether the risk is attributable, whether the mortality is attributable to the pneumonia, or is it because of the underlying comorbidities. Those things needs to be analyzed further. But this just hypothesizes that there is a possibility of a long-term sequelae happening secondary to pneumonia. And prevention, smoking cessation in smokers, and vaccination, influenza pneumococcal vaccination are recommended. In influenza is for all patients, and pneumococcal for at-risk individuals is recommended. And this says the percentage of vaccination in US in 2019 to 21. So it is somewhere around 25%. And this by itself seems to have decreased the burden of pneumococcal pneumonia. So it has the percentage of pneumococcal pneumonias has reduced, and influenza seems to be proportionately going up. And of course, with COVID, that seems to have overtaken all the others as well during this period. But whether it is because of pneumococcal vaccination or whether it is because of the overriding of any of the other viral pneumonias needs to be probed further. But the thing is, when compared to European population, US seems to have got a decreased burden, seem to have documented a decrease in trend. So it's possible that pneumococcal vaccination is also contributing to it. So it's something that we also can pick up and encourage vaccinations to so as to improve, decrease the burden of pneumococcal pneumonia, and also probably some of the cardiovascular and respiratory sequelae secondary to that. So, having discussed about community-acquired pneumonia, I'll just briefly go through ventilator-associated pneumonias. I'm not touching too much on hospital-acquired pneumonias because there is not too much of data on hospital-acquired pneumonias per se. Most of them which discuss about hospital-acquired pneumonia are in fact about ventilator-associated pneumonias. So the microbiology seems to be a little bit different. Here we do expect MDR pathogens. Here the list says Pseudomonas first, MRSA, Acinetobacter, and some ESBL bacteria, carbapenem resistant strains, and some fungal causes as well as the MDR pathogens. But in CMC, almost 60 to 65% of isolates secondary which have caused ventilator associated pneumonias have been Acinetobacter. So there is a difference in the microbiology of Western literature compared to our literature. So we'll have to cater to our needs. So some risk factors and preventive measures. This is taken from a table from Harrison. So it's because of colonization of pathogenic bacteria in the oropharyngeal region. So one preventive strategy suggested is avoidance of prolonged antibiotic courses. Consider oral chlorhexidine so as to prevent elimination of the normal flora. That's why it has been suggested. But this again, it's not a strong recommendation. It's only a low quality evidence. So this is something which can be considered, not that it is must that it should be done. So, but in any ways, it's good to have some rational antibiotic regimens for other benefits as well. And one more is suggested is short course prophylactic antibiotics for comatose patients, because there appears to be some amount of aspiration which happens around the time of intubation. So it might be good to give a short course of prophylactic antibiotics. Once again, it's all the recommendations are that have been discussed here are of moderate to low quality evidence. So it's only a conditional suggestion rather than a strong recommendation. So, and post pyloric enteral feeding, so as to prevent gastroesophageal reflux, which could probably cause ventilator associated pneumonia, and to avoid PPIs, long-term PPIs, to in order to prevent bacterial overgrowth in stomach. That's another thing that can be suggested. And the one thing which we can definitely all follow is to prevent cross infection from other colonized patients. Hand wash. This is pretty simple. Simple to do, but difficult to follow. With an NABH inspection also coming up, we need to make sure that we do it regularly, not just for the sake of it, but we can use that as a motivation factor to continue practicing it, so that at least because of this, we can prevent some form of cross infections. And the practice of in a rapid sequence intubation technique, avoiding sedation uh, uh, and decompression of small bowel obstruction before endotracheal intubation, that can prevent large volume aspiration. So that's something which we can consider. And uh, change ventilator circuit when it is soiled and with a new patient, so as to prevent infection is occurring due to the ventilator circuit. And whenever there is a possibility, use non-invasive ventilation in place of endotracheal intubation, and try to decrease the duration of ventilation and consider early tracheostomy in patients who are requiring long-term ventilation, and head end elevation to about 30 to 45 degrees and aspiration of subglottic secretions can probably minimize, and tight glycemic control and lowering the hemoglobin threshold are also suggested in view of altered lower respiratory host defenses. Of course, tight glycemic control is a bit of uh, I mean, it has got a bit of a caveat because we all know that tight glycemic control, there has been a randomized control trial in intensive care unit where tight glycemic control has been compared with a reasonable liberal glycemic control. And there appears to be a higher mortality with very strict glycemic control because of higher chances of hypoglycemia. So for that aspect, we would give a reasonable liberty of glycemic control. We would not prefer tight glycemic control. So in overall, we would probably not consider this, but it appears that it may probably have a role in preventing ventilator-associated pneumonias. And this is from our HACC. So this is based on our microbiology. So given that given the challenges in making a diagnosis of community-acquired pneumonia by itself, a diagnosis of ventilator-acquired pneumonia is much more challenging, and it requires an array of clinical features, some labs and chest X-ray as well. So the presence of fever, change in the quantity and character of ET secretions with worsening oxygenation, and some corroborative blood evidences in the form of leukocytosis, leukopenia, and chest X-ray showing some new and worsening infiltrates increases the probability of a ventilator-associated pneumonia. And ET aspirate be considered when there is a suspicion of a ventilator-associated pneumonia, because this can even just be a colonizer. So this will not carry any meaning if the patient does not have any of the clinical features, labs, plus or minus labs and X-rays. So, and if there is significant growth, the most common bacteria that we have identified here are Acinetobacter, Pseudomonas, Klebsiella, and Stenotrophomonas. And the antibiogram has suggested that sulbactam, minocycline, tigecycline, polymyxins to be the ones usually susceptible, Acinetobacter is susceptible to, and for Pseudomonas it has been polymyxins, and for Klebsiella it has been ceftazidime, avibactam, estrionum or polymyxins, and Stenotrophomonas, cotrimoxazole or levofloxacin. But what we find is that most of these seem to be polymyxins, and that's why the empirical treatment while awaiting culture sensitivity is currently polymyxin as per HACC at 15 lakh units loading dose followed by 7.5 lakhs BD. And if there is a suspicion of MRSA, to consider vancomycin. And the duration of antibiotic, once again, it's a bit of a gray area, can be 8 to 10 days and can extend to 2 weeks if the patient continues to be sick. So I think at this point I'll stop and I'll open the session for questions. Yeah, one more thing which I wanted to say is, what about anaerobic cover for someone who presents with aspiration pneumonias? Yeah, sorry, I didn't include that in the slide. I wanted to include that as a slide, but as I said, it didn't work. Of course, most of our patients, we give piperacillin, tazobactam, and azithromycin or doxycycline. So piperacillin, tazobactam does cover anaerobes as well. So we don't need to worry too much about it. But in case we are going to say if we are going to consider ceftriaxone and azithromycin, which will not have an anaerobic cover, should we give an anaerobic cover in the form of metronidazole or clindamycin or something like that? Yeah. Thing is, recent guidelines do suggest that a separate anaerobic cover is not warranted. And whenever aspiration pneumonia happens in the community, then we follow the antibiotic regimen as recommended for community acquired pneumonias. And there is not great deal of benefit in adding an anaerobic cover to the conventional regimen of 1 beta lactam plus azithromycin. But anyways, since we are using piperacillin tazobactam, that nullifies this question at all for us. Okay, any questions?
Curve 65 more than 3, steroids is better as what we have currently said. So even if there is no hypotension and there's this confusion, respiratory rate high and age more than 65, we can go ahead with it.
Yes, so that's what the systematic reviews indicate. So, as I said, there have been a difference in Picot statement of each and every study that were included among the 12 trials that gave this particular statement. So, what they have used is if more than 50% of the patients required ICU, they have taken that study to be including severe community acquired pneumonias. And similarly, all those who had these scores cut off, they have considered it to be severe pneumonias. And all those who required ventilation, intubation, they considered to be, and also those who had shock. And only because there has been all these differences, it is not a very strong recommendation, but it is still a moderate or a conditional recommendation. So it can be considered. So it is still not that you must give steroids for all these criteria, but we can consider these for all severe community acquired pneumonias, not only for shock and those needing intubation ICU, but also based on these scores, it can be considered. Okay. There are no questions. Thank you. Thanks for coming.